The title of my talk right now is essentially perioperative therapy for bladder cancer. And I know there's sort of an ongoing debate exactly what perioperative means, but in my interpretation, this is either neoadjuvant or adjuvant or a combination of for localized bladder cancer. So this talk, it seems to be getting ever bigger. When I first started this, I think I had a set of slides and I kept having to add to it. So the way I've sort of organized this talk is to kind of start with chemotherapy and immunotherapy, and then eventually go on to some parting thoughts. Over the talk, I also kind of want to highlight 3 specific studies. So I'm going to start with what we know, and what we know is basically chemotherapy and radical cystectomy. So the radical cystectomy, as we know, doesn't cure everybody. Overall, basically about 50% of people will eventually recur and pass from even if they just get surgery alone. There was one study from Switzerland that demonstrated this. This was about a retrospective analysis of a single institution experience. About 500 patients were reviewed here, and all of these patients had no negative disease and muscle invasive disease. And for those patients who, and none of them, of course, received chemotherapy. For those patients who had less than PT2 or equal to disease, the 5-year survival rate was about 62%. For those who had pathologic T2 disease, their survival was about 49%. And for those who had no positive disease, at the time of pathologic review, survival was about 26%. So otherwise, going on towards chemotherapy, we know that chemotherapy along with surgery works. In terms of neoadjuvant chemotherapy, it carries a Category 1 recommendation in the NCCN guidelines. This is based off experiences from prospective studies. And also, as you can see here from the famous subgroup analysis on the right side there, this is from the ABC meta-analysis where they looked at single-agent cisplatin trials versus combination trials using a platinum combination. Basically, there was definitely a improvement with the neoadjuvant chemotherapy in combination with a cisplatin-containing combination. Adjuvant chemotherapy, however, while we do use it, it doesn't carry as much. It's not supported as well as neoadjuvant chemotherapy, and this is partly because of adjuvant trials not being able to fully enroll. And so, but these patients obviously still continue to have high risk of recurrence, and so by extrapolation, we still offer a cisplatin-containing combination chemotherapy regimen. Now, chemotherapy, of course, has had its own issues. Basically, about 40 to 50% of people are not going to be cisplatin eligible at the outset. We lose some of these people after surgery as well. Maybe about 20 to 25% of people are not going to be chemotherapy candidates afterwards additionally. And also, there's been multiple studies looking at the adoption of neoadjuvant chemotherapy, and it's certainly a significant proportion of people who do not receive neoadjuvant chemotherapy. So delving into chemotherapy a little bit more closely, the SWOG 8710 trial and also the international BA06 trial, these are 2 trials that looked at the use of MVAC and also CMV. Both these trials did eventually lead to an association with improved overall survival with neoadjuvant cisplatin-based combination chemotherapy. And from these 2 trials, there are also some other educational points that were revealed. One was that the PT0 rate seemed to be a good prognostic marker in terms of overall survival. And then the other conclusion was that a lot of these combination regimens were associated with pretty hefty chemotherapy toxicities. And so nowadays, fortunately, we don't use actually CMV or conventional MVAC anymore. Most popularly, I think right now, people are using cisgem or dose-dense MVAC. And both these regimens, as you can see in the table on the right-hand side here, and these include a couple of trials with cisgem and accelerated or dose-dense MVAC, you can see the PT0 rates are pretty similar to what they initially saw on the two early trials, including also the downstaging rate. But more importantly, if you go down a little bit further, if you look at the rate of grade 3 to 4 adverse events, it does seem to be less compared to before as well. However, cisgem and also distance MVAC are often criticized for not being tested in a phase 3 setting, and so it's by extrapolation that we're using them up until now. And I wanted to just kind of bring this to everyone's attention. This is the VESPER trial, and this is a French trial that is a phase 3 randomized trial. And on this trial, they were looking at to compare cisgem and distance MVAC in a perioperative muscle invasive bladder cancer setting. The inclusion criteria included, of course, patients having muscle invasive bladder cancer, but patients were allowed to either have neoadjuvant chemotherapy or adjuvant chemotherapy. They were planning to enroll 500 patients. Patients were randomized to either cisgem times 4 cycles or distance MVAC times 6 cycles. The primary endpoint was disease-free survival. Secondary endpoints included PCR for the patients who had neoadjuvant chemotherapy, of course, survival and time of progression and safety. Looking at the study population on the right-hand side, I know it's a little bit hard to see, but basically about 90% of the study population received neoadjuvant chemotherapy. So by and large, this was a neoadjuvant trial essentially. 10% received adjuvant treatment. If you look at the small numbers, there were slightly higher high-risk patients in the dose-dense MVAC arm versus gemcitabine and cisplatin. And on the adjuvant side of things, 66% of the population had node positivity. So a little bit, again, of a busy slide here, but I'm going to try to break this down. So looking at the two pie charts here, in the blue are the patients who were treated with cisgem, and in the orange are the patients who were treated with dose-dense MVAC. And on the left-hand side, this represents the patients who had adjuvant chemotherapy. On the right-hand side, neoadjuvant chemotherapy. And the darker colors indicate the people who completed all the planned treatment, okay? And the lighter colors are people who received less. So starting with the first pie chart here, you can see that most people who were planned to have adjuvant chemotherapy actually did not finish their chemotherapy. Less than half, in fact, for both cisgem and dose-dense MVAC. However, if you looked at the total people who had cisgem, most people were still able to at least complete 4 cycles, although in the MVAC arm, basically very, very few people were even able to complete a lesser regimen of 6 cycles of dose-dense MVAC. Moving on to the neoadjuvant chemotherapy pie chart. As you can see again, cisgem seemed to do a little bit better in terms of being able for patients to be able to complete their chemotherapy. Although both arms, patients were able mostly to complete the planned number of cycles. Going down to table 3 and table 4 on the bottom, table 3 represents those patients who got hematologic toxicity, and table 4 are the non-hematologic toxicities seen in the trial. And overall, in terms of dose-dense MVAC, more people had anemia, and also there was a trend towards having higher rates of febrile neutropenia as well with dose-dense MVAC, as well as GI toxicity, asthenia, and chemotherapy-related deaths, actually. There were 3 deaths in the dose-dense MVAC treated patients as opposed to 1 patient in the cisgem treated patients. The investigators also have reported and published their experience on pathologic response. And again, the primary endpoint was disease-free survival. So this is, we still haven't really seen the primary endpoint. But in terms of pathologic response, this is also kind of tiny to see, but I kind of blew it up here on the bottom here. In terms of complete response or PT0 rate, overall there was no significant difference between the two treatment arms. As you can see, in terms of downstaging, patients were more likely to be downstaged with a docents MVAC as opposed to cisgem. And also the rate of having organ confined status was also higher with docents MVAC. Interestingly, the investigators also looked at chemotherapy delivery as well, or chemotherapy, I guess, in terms of patients who were treated with a dose intensity versus cumulative dose of chemotherapy and whether or not they had any bearing on response. And in the red boxes here, you can see that those patients who had in the second red box here, patients who had gemcitabine and cisplatin, those who were able to complete 4 cycles versus less than 4 cycles seemed to have a higher chance, a significantly higher chance of having a PT0, downstaging, and also organ confined rates. They tried to do the similar sort of assessment for docents MVAC, and there was no significant difference between lesser or more chemotherapy. So in conclusion for VESPER, we're still waiting for the disease-free survival outcome data, but overall what we have seen so far is that there is a better local control rate with neoadjuvant docents MVAC versus gemcitabine and cisplatin, but not PT0. Compared to neoadjuvant chemotherapy, patients were less likely able to complete all of their adjuvant chemotherapy as per plan. And also, we saw more toxicities with docents MVAC as opposed to cisgem. And they do have some analysis on variant histologies, which I'm personally pretty excited to see, but it has not been reported on. Moving on to immunotherapy, there seems to be an ever-growing amount of immunotherapy trials. So rather than talk through all of them, I decided to try to put some of them or most of them onto a big chart. And unfortunately, it's kind of small at this point. But basically, as you can see here, there's quite a few trials. These are mostly phase 1, phase 2 trials. The study populations of these patients on the trials include cis-ineligible and also cisplatin-eligible patients. They overall are relatively smaller numbers, and all of them have variable percentages of people who have T2 rates versus T3, T4, and also some of them did include node-positive patients as well. You look across the top, some of them included patients who were treated with just single-agent immunotherapy. Others were treated with chemoimmunotherapy. Some of them were treated with immunotherapy combinations, actually, as well. So there's quite a bit of variability. But overall, if you look at the T0 rate and the downstaging rates, overall, they seem to be within the same ballpark as what we expect with neoadjuvant chemo. And then if you look at toxicities, they kind of vary quite heavily overall, although there's not a lot of complete information here. As you can see, one trial reported only 14% grade 3 to 4 adverse events, and others included rates up to 84 or even 50 plus percent. A lot of these trials are looking for predictive biomarkers, and I think that's very, very exciting, but so far we haven't seen anything consistent. In pretty much the same tune for the adjuvant studies, here is a chart as well. These were pretty much all phase 3 trials, and the numbers that were planned for enrollment are quite high. Overall endpoints, primary endpoints included overall survival, disease-free survival. For those on the right-hand side, the last 3 columns there, these actually included people who truly got perioperative treatment. And so the endpoints reflect that as well. There are trials looking at PCR versus also event-free survival. And going into the next trial here, I wanted to highlight the Checkmate 274 trial. And so this was an adjuvant trial using nivolumab in high-risk muscle-invasive bladder cancer patients. They did enroll 709 patients. Key inclusion criteria included patients who had received neoadjuvant chemotherapy, T2 to T4A, or node-positive patients. People who did not receive neoadjuvant chemotherapy were enrolled if they had T3, T4, or node-positive disease. In terms of stratification, they did look at stratifying by PD-L1 status using the 28-8 antibody. They also looked at whether or not patients had neoadjuvant chemotherapy, and also nodal status. Patients were randomized 1-to-1 to either receiving nivolumab for a year every 2 weeks versus placebo, as opposed to observation for up to a year. The primary endpoints included disease-free survival, not only in the overall intention to treat population, but also the PD-L1 positive patients. Secondary endpoints included patients who included non-urinary tract relapse-free survival, disease-specific survival, overall survival, and exploratory endpoints included distant mets-free survival, safety, and quality of life. So looking at the study population a little bit more, they did include certain key characteristics that included some of the patients, about 20% had upper urinary tract disease, about 50% actually had node positive disease, 40% were PD-L1 positive, and about 40% also had previous chemotherapy. And here are the co-primary endpoints. On the left-hand side, the DFS and the intention to treat population. On the right-hand side, this is the PD-L1 positive population. And as you can see here, the results were significantly in favor for nivolumab for both of the co-primary endpoints. In terms of subgroup analysis, this is a big chart, so I wanted to zoom in a little bit here. And patients who, certain subgroups actually had more improvement, included those who had node positive disease, also T3 versus N2 and 3 disease, and also previously treated patients with chemotherapy. Overall, as you can see here, adverse events showed that that nivolumab was relatively tolerable. Overall, in terms of treatment-related adverse events, there were about 18% of patients treated with nivolumab who had grade 3 or greater adverse events, as opposed to 7% on the placebo arm. Only seldomly did these actually lead to discontinuation, 7% versus 1%. The most common side effects included pruritus, fatigue, diarrhea, and rash. And most common grade 3 side effects included an elevated lipase or amylase. There are a lot of ongoing selected trials as well, and I've just shown a couple here, but immunotherapy is being looked at in combination with various treatments, and those include other chemotherapies, other targeted therapies, in combination with chemotherapy and targeted therapy, and also antibody-drug combinations or conjugates. So to kind of try to wrap this up a little bit, in terms of looking at neoadjuvant versus adjuvant considerations, if you treat patients with neoadjuvant treatment, some of the pros or advantages that you'll get downstaging at the primary, early systemic disease for a disease that's most likely to recur systemically, you'll be able to get that in earlier and address that. You also get an in vivo test of patients from their treatment as well, which definitely is very practical to use. And also neoadjuvant chemotherapy or treatment seems to be more easily tolerable. Certainly, as you can see from the VESPER trial, I think that's very evident. But on the flip side, though, if you treat everybody with neoadjuvant chemotherapy, there are certainly going to be people who don't necessarily need treatment, and so there's definitely a risk of overtreatment. And also for those patients who don't respond at all, of course, that could result in a delay to definitive therapy. In terms of adjuvant therapy, basically there is a better selection of high-risk patients. Patients, however, on the other hand, will also have to be dealing with post-op recovery, so that has to be factored in. Also, it's also unknown exactly how long we should do these, adjuvant treatments. I mean, should it be 6 months? Should it be 12 months? Should it be 2 years? We really don't know, and hopefully some sort of biomarker is able to kind of guide this a little bit, although I think the evidence right now is sort of not well ripe, I guess. But ending on biomarkers, I wanted to finish with one last trial, which is the IMvigor010 trial. This was a trial that was negative, unfortunately. It did get published earlier this year. This was also an adjuvant study using atezolizumab versus observation in high-risk muscle-invasive disease. Patients were randomized basically to a year's worth of atezolizumab versus not, and about 809 patients were recruited. Primary endpoint was disease-free survival. I'm going to kind of skip ahead a little bit here. And as you can see here, in terms of the primary endpoint, there was no split of the curves, and there's no difference between adjuvant atezolizumab versus observation, even by PD-L1 status. However, the investigators did actually publish an analysis in Nature earlier this year as well. I think actually just a few months ago, and this was very interesting. So out of all the patients who were on the trial, 581 actually were evaluable for circulating tumor DNA. And out of these patients, 37% were actually positive for ctDNA. And as you can see here, let me explain the chart here a little bit. Those who had positive circulating ctDNA versus those who had negative ctDNA are shown here in the two curves at the top versus the two curves at the bottom. The patients in the darker represent the patients who actually were treated with atezolizumab versus observation, who also had positive ctDNA. As you can see here, for the ctDNA positive patients, those treated with atezolizumab seem to have an improvement. So I think that's very exciting. I think this is, to me at least, one of the first time in bladder cancer I've seen this kind of data, and definitely is very thought-provoking, and I think they will be able to hopefully come up with something similar or maybe expand upon this in the future. So in conclusion, cisgem and dose-dense MVAC remain important perioperative chemotherapy regimens. Nivolumab is the first immunotherapy agent to be approved for adjuvant treatment for muscle-invasive bladder cancer. Research is going to be extremely important to help us improve our knowledge base and also improve our outcomes for these patients. Thank you very much.